Good afternoon and welcome to the East Midlands Ambulance Service and General Meeting. We're going to be relying very heavily on network connectivity throughout this session, so bear with us. Really hope we don't have any difficulties. If we do, we'll work through them as quickly as possible. We're going to be videoing today's meeting as well, and it will be published on our website probably in about a week's time, so look out for that. Today's AGM is a mixture of a conversation and also some pre-recorded videos from our Executive Director colleagues, which we'll be sharing with you throughout the session. Then at the end of the presentations from our colleagues, we'll open it up to questions and answers. We'll try and answer as many questions as we possibly can today, so please feel free to place your questions in the chat box, and we'll get to them at the end of the meeting. So just before we start with the videos, I just wanted to introduce our Chief Executive, Richard Henderson, who's with me this afternoon. Richard is here on my left, and Mike Naylor, our Finance Director, who's also in the room with me on our right. My right, sorry, and we'll each be talking at some point during the presentation this afternoon. But just before we get into the first video, Richard, I wonder if you'd just talk about what the key challenges were for 2021. It was a very demanding year because of COVID, and just wondered what your reflections were on that year. So
thank you, Paul. So as a Chief Executive, it's been a huge privilege to have this role through such a challenging period, and it goes without saying, each and every one of our employees and the people who support the organisation have been through immense change and pressure. We've had some really tough periods. The activity and pressure the organisation has had to face has been absolutely phenomenal at times. Our own colleagues, each and every single one of them, have been directly or indirectly affected by COVID. We've even sadly had the sad passing of one of our own colleagues and many other colleagues who have suffered adversely as a result of COVID. So a hugely tough year. What I would also like to say is we've really seen some exceptional demonstration of teamwork, camaraderie, where our colleagues have come together to be able to work together to deliver the types of services that we've needed. It's meant that many of our staff have worked in different ways, so not necessarily doing their normal core role. So people who may not have a patient-facing role, for example, or working in the emergency operations centre, have had to change their roles, so changing their job role completely to be able to support the front line. So an example of that would have been in the early days where colleagues were delivering PPE, our logistic teams were procuring PPE from through very, very challenging circumstances, many of which was well publicised in the media. We've had our corporate staff working in different environments and working at different locations, as an example. We also know from a day job that our frontline ambulance staff have had to be working very, very difficult and challenging situations. So wearing PPE and full level 3 PPE in those really difficult situations, and that's something which has not been easy for any one of them. And on behalf of them, thank everyone for what they've done throughout that time. We've had immense support from a huge team of volunteers. So many people who have stopped doing their normal jobs to help the ambulance service, be that in direct patient care or indirect patient care. So some huge support that we've received. So a very challenging year. I am pleased to say that we've delivered very well to many patients. Many patients got an extremely fast response at their time of being, and that's something which each and every one of the organisations should be really proud of. We know, however, there are some patients who have had to wait far longer than they needed to, and that's something which we have to make sure we can continue to improve and respond to those patients. But yeah, that's certainly some high-level reflection.
Thanks, Richard. I think as well, it's been a very challenging time for the whole of the NHS during the pandemic, and I just wondered what particular partnerships we've developed during that period and how we've benefited from those partnerships.
Yeah, you're absolutely right. We haven't been able to do this on our own. We've had to work very closely with the wider healthcare system, so the whole health and social care system. We've developed and we're very effective with other partners, so police and fire. A really good example of that is where we've had fire rescue personnel working on urgent care ambulances, helping support frontline delivery so that our frontline crews could prioritise the high priority category 1 to category 2 emergency calls. So that's a really good example of where we've worked differently with partners and certainly volunteers. Not just around direct patient care, but we've had many volunteers helping with the vaccination programs, which worked very well. We got many of our staff and our support experts vaccinated very quickly as soon as the first vaccines were available. So that's something which, again, we're all very proud of.
Thanks very much, Richard. That's a really good introduction to the body of our AGM today. And we're going to hear now from some of our other executive colleagues about their reflections on the year just gone. And first of all, we'll move to a video from Nicola Bramall.
Hello, my name's Nicola Bramhall and I'm Director of Quality Improvement and Patient Safety here at EMAS. We launched the Quality Improvement Strategy because we were really keen to set out our aspiration to deliver outstanding services all of the time. And it really does set out how we will look to improve our culture, become a real learning and improving organisation, and explain to everybody, the staff who work for us, the patients and public who use our services, so yourselves, and our partners that we work with in the healthcare system, how we want to improve over the next 5 years so that we're delivering high quality services all of the time. We also really wanted to make sure that people could understand what it was that we wanted to do, what it would look and feel like to be in this improved organisation in 5 years' time. So as somebody receiving care from us, as a staff member working in the organisation, and as the many partners that we deliver healthcare services alongside. The quality improvement vision is really that quality is embedded in absolutely everything that we do. So we assure, we learn, we improve, we innovate, and we collaborate with partners so that we are delivering those high quality services at all times. We recognise that a big part of achieving that aim is to change the culture within the organisation to a really open and learning culture where we learn from when things go wrong, but also when things go well. So it's about encouraging our staff, patients and public, so yourselves, to come forward and tell us about things that we could do better, and to really act on that and put in place measures so that we are delivering quality all of the time. And we recognise that to deliver quality, we really need to get all 5 domains of the Care Quality Commission quality standards right. So we need to be caring, we need to be responsive to the needs of our population, we need to deliver effective services, we need to be well led, and we need to be safe. Unfortunately for us, that spells out crews, so it's quite easy for all of us to remember. In each of those domains of the framework, we have engaged with our staff, with the public, with patients who've used our services previously, and with partners who we work with in the system to identify what are the priorities under each one of those domains. And within that, we've identified some actions that we need to take. We were really keen in developing the strategy that this wasn't something that sat on a shelf gathering dust, that it was something that was living and breathing, that set out for everybody the part that they could play in our improvement journey. So regardless of your role within EMAS or your role in the community, you know how you can help us to improve over the next few years. So what we did was we identified actions for the first year, and also identified a number of metrics that we could monitor so that we could measure our improvement journey. And what we do at the end of each year is we come out, we engage again. It's been a little bit different in the last year because obviously we haven't been able to do a lot of face-to-face engagement, but we have still engaged so that we can identify what are the priorities, what are the things that we still need to do which will continue us on that improvement journey. think the pandemic has been challenging for all of us, those of us working in healthcare, and you, the public, have had to also adapt. So it's been a very, very challenging year, but I'm really pleased to report that despite those challenges, I mentioned earlier that we had some metrics that we'd identified to monitor progress. There are 58 of those, and at the end of year one, 44 of those, so 75% had actually improved. And really reassuringly, because I said right at the outset that this was very much about changing our culture, what I'm really pleased to report is that of the 17 staff opinion survey metrics that we identified, all 17 of those have improved in the first year. If I can give you an example of that, one of them is we had a 10% improvement in the number of staff who respond positively to the question about whether they're treated fairly if they're involved in an incident. Now, why is that important? That's really important because we know that if staff feel able to come forward, they feel that they won't be treated unfairly, that they will be listened to, that we will make changes. That means that we can continue to improve, and that is really, really important as part of our improvement journey. And one of the things that we're really proud of that we introduced during the pandemic year, and probably helped a little bit by the pandemic year, because I think we all had to think differently about how we engage and communicate. So we introduced fortnightly learning from events sessions. We deliver them via MS Teams, so they're virtually. They can be accessed either live by our staff, or we actually record them so that staff who aren't able to attend them live can access them at a later date. And they're basically run by our quality and clinical directorate teams, with involvement of sometimes patients who have been involved in cases, or the staff who have been involved. And it really is about learning from things that have happened. Now, we've called it learning from events rather than learning from incidents, and that's a really important distinction, because we believe that yes, you can learn from when things go wrong, but equally you can learn from when things go well. So, you know, what was it about that really positive case that meant that all of the ingredients were in place to make a really positive experience and a good outcome for that patient? And by doing that, we can hope to replicate that across the organisation. So it's really important that it's learning from when things go well as when things go wrong. Listening to staff and patient feedback is really, really important in terms of identifying where we can continue to improve. One of the things that we've done in the last year, because we recognised that we had very few staff coming forward with concerns under our Freedom to Speak Up process, and those staff that were coming forward tended to do so anonymously, which kind of made us think they were worried about doing so. So we've spent a lot of time in the last year developing that process, and sharing the benefits of raising concerns through that process with our staff and how they'll be supported during that. We introduced a module that all of our staff can do. It's about a 20-minute module. It explains the benefits of speaking up, how to speak up, what support and action will be taken once staff speak up. And I was really pleased that within the first month of launching that module, over 150 staff had completed the training. It was obviously a lot of interest in that area. And actually, as it stands now, we've got well over 1,000 staff have completed that module. And we have seen both an increase in the people coming forward with concerns, but also those that are coming forward and don't wish to be anonymous. They're quite happy to share their details and be open with us, which is great, because it means we can do a better investigation. And of the referrals that we received last year, all of those have been resolved to mutual satisfaction, really, which is really positive. We of course receive compliments from patients and the public, so yourselves, so thank you for those. They're always a real boost for our staff, so please do continue to tell us when things have gone well and you've had a positive experience. We've also in the last year particularly had a focus on staff recognising each other. It has been a really, really difficult year, and it's been really important that we can give those little boosts to people. So we've really encouraged what we call excellence reporting, which is whereby a staff member can identify either a team or an individual who's gone above and beyond to support them or to deliver care to patients. And we've seen a significant increase in the numbers of those reports that have come through in the last year, which is great for our staff, given the difficult circumstances that they've been working in. One of the things that I'm really proud of actually in the last difficult year has been that our patient voice group were committed to continue to work with us, and what the patient voice groups do is really help us to look critically at the things that we are doing, the changes that we're making, so that we can make sure that any changes that we make are actually an improvement and not just a change. So they really help us to see things from a patient's perspective, and are very keen to come forward and tell us if they think we're getting it wrong, but also when we're getting it right. And what was really positive through the pandemic year was, despite the fact that we could no longer meet in person, they were all really keen to embrace the technology that enabled us to continue to meet virtually in a safe way, and they have continued to support us to make sure that the developments that we've made are in patients' best interests, which is great. And I'd like to take the opportunity actually to thank John Crouch, who heads up the patient voice groups, and all of the members who've really supported us in the last year. It has been a good year. It's been a good first year, but I think none of us are resting on our laurels. We are really keen that we're not just going to be good enough. We absolutely want to excel in everything that we do. We've recognised that a big part of that is continuing to change that culture and really capitalise on the improvements that we've made in the first year, but continue to go further. So it's about making sure that we continue to be a learning and improving organisation, that we work with our staff, with the public, yourselves, and with our partners to do everything that we can to continue on that improvement journey. And for me, it's about making sure that we also capture that patient voice. As I said, we've done amazing in terms of continuing to communicate and engage with our patient voice groups. What we'd really like to see happen in the coming year is that we expand those even further and make sure that they really are representative of the diverse populations that we represent.
Thank you very much, Nicola, for that comprehensive run-through and highlights of the quality improvement year that 2021 was, despite the pandemic. I think we'll move straight over now to our second video, which is by our Medical Director, Dr. Leon Roberts.
Hello, I'm Dr. Leon Roberts. I'm the Executive Medical Director here at East Midlands Ambulance Service. When I first joined East Midlands Ambulance Service, I was asked to chair the Clinical Operating Model Board here at the Ambulance Service. Developing clinical services for an ambulance service is absolutely key, not only during COVID, but throughout the natural development of services. Gone are the days where we scoop and run and just take patients to the nearest hospital. The Clinical Operating Model Board has been devising various different levels and responses within our communities. And a big thank you to all patients and relatives that have been working with our crews on scene, discussing alternative pathways and different access to care. We've been utilising same-day emergency care units across our hospitals. These are units that assess conditions such as deep vein thrombosis, non-cardiac chest pain, skin infections that can all be dealt with on the same day, but not necessarily in the emergency department. This is driving down the number of ambulances that are needing to go to our very busy emergency departments, helping the system overall. We were really fortunate to use some additional COVID funding to provide doctors in our control room 12 hours a day, 7 days a week, giving access to enhanced clinical support and advice on scene, supporting many of our frontline crews in making difficult decisions with patients and relatives. We have also, throughout this period, focused on our immediate life-saving work, such as resuscitation, and we're delighted to be commencing our new resuscitation strategy. Throughout the last year, we've been developing a new resuscitation strategy here at East Midlands Ambulance Service, what would be termed the cardiac arrest strategy. There's been multiple input from many directorates at our ambulance service, both clinical, quality, operational, and including our clinical audit and research unit, in order to assess our outcomes from cardiac arrest. We are absolutely dedicated to improving early CPR instructions to our patients and relatives on scene. We're absolutely dedicated to improving access to defibrillators in the community early, and we're absolutely dedicated to getting the right team to patients in cardiac arrest. This is all part of a 5-year strategy to improve our outcomes from cardiac arrest. The outcomes we focus on are where we spontaneously get the heart to beat again, and that survival at 30 days after the event. We'll be working with all operational and control room colleagues to improve those outcomes over the next 5 years. As part of the resuscitation strategy, we identified that leadership on scene was key. Resuscitation is everybody's business at East Midlands Ambulance Service, from the first responders providing basic life support to the additional members of the team joining the efforts to provide advanced life support and positive outcomes from cardiac arrest. National and international evidence has showed that having a coordinated leader on scene can make all the difference to those outcomes. We've spent this year training over 100 members of staff across all 5 counties to provide that leadership. We've been working with control room colleagues to allocate those cardiac arrest leaders to patients where we genuinely believe we can get a more positive outcome. This is all part of that 5-year strategy, and we really welcome review of those outcomes over the next few years. As part of deploying cardiac arrest leaders to scene, they will also provide that very important support to colleagues. Anybody watching the events during the Euros and the collapse of the footballer on the pitch can see how stressful that situation can be for bystanders, family members, and our responders. Cardiac arrest leaders will ensure that following cardiac arrest, there is an adequate debrief and highlighting any learning and support that might be needed for both colleagues, but also the wider service going forward. We will set up an EMAS resuscitation group in order to review outcomes from cardiac arrest, where things have gone really well and where things have gone not so well. Part of our dedication to learning from events and improving care to patients. Over the last year, we've been developing and recruiting to the specialist practitioner role at East Midlands Ambulance Service. Feedback from our annual staff survey and also understanding of the clinical need in the East Midlands identified that this role could make a difference to patient outcomes and options in the community. We spent the year recruiting and training the specialist practitioners and have nearly 40 out across all 5 divisions of the ambulance service working alongside frontline colleagues. One of the innovations has been to have a specialist practitioner in our control room, working with control room staff and the clinical assessment team to identify appropriate patients for our specialist practitioners. The specialist practitioners are extremely proud to discuss with patients complex needs, complex outcomes, and different pathways to support people in the community where needed. But they also function as cardiac arrest leaders and senior clinicians, assisting staff with decisions for patients as their advocates out there. We really welcome further recruitment over the next year and are monitoring those outcomes from the specialist practitioners closely. Over the last few years, there's been a real big change in the way that the ambulance service cares for patients, with a real focus on decisions in the community. We're really proud that East Midlands Ambulance Service was one of 3 chosen to pilot calling back some of our lower acuity work, our lower category work. This has allowed our experienced clinicians in the control room to very early on in the care discuss alternatives to an ambulance response. I think the public perception would be that when an ambulance arrives, many patients are taken to hospital. This is just not true in the modern ambulance service. We're really proud that over the last year, only about 50% of our patients are taken to an emergency department, about 5% taken to an alternative destination at the hospital. In the modern ambulance service, over 10% of our work is dealt with over the phone, and we're grateful for our clinical assessment team and our patients and relatives working together to form those alternative pathways.
Thank you very much, Leon. And just while we're waiting for our next video, a gentle reminder that if you have any questions, start to put them in the chat box so that we can pick them up at the end of the presentations and answer them straight away today. Our next video is from Mike Naylor, our Director of Finance. who will take us through the annual accounts.
Hello, I'm Mike Naylor, Director of Finance and Deputy Chief Executive of East Midlands Ambulance Service. 2021 was a very challenging year, and the reasons are well rehearsed elsewhere in this report. But for the financial regime, it was very different. We moved on to a block contract, i.e. we just got paid a set amount, and that set amount was based upon a level of activity that existed before the COVID crisis started. This meant that we had to manage our finances within a prescribed envelope. We got some additional money for COVID, which alleviated some of the exceptional expenditure we incurred to combat the disease. The COVID monies were meant to ensure that hospital trusts, ambulance trusts and the health service generally had enough money to fight the disease and ensure that we kept control of it. So for us, we used it in 2 or 3 main ways. First of all, we put additional resources out through either contracting with the private sector or overtime with our own staff. And that meant we could put more ambulances on the road, which helped our response time. Also, this money then helped to fight the disease internally. We use it for deep cleaning, and we had cleaning regimes for ambulances outside A&E departments, for instance. We used it to buy specialist bits of equipment, such as the mechanical masks that our crews were issued with. So instead of having to use disposable face masks, they use electronic hoods, which help protect them from the disease. So also we used it for some internal estates work, for instance. We rejigged some parts of the EOC, put some doors in to make the flow of people much more smooth. We put screens up protecting people in the EOC and elsewhere within the trust. So all those sort of measures were made possible by the additional money that the Department of Health and the Treasury gave the trust. This year, very much similar to last year, is that we've rolled forward a regime which gives us a block contract. So we've got certainty of income, but this year it will be doubly difficult because we will have a block allocation based upon a level of activity which is far below what we're experiencing at the moment. Post-COVID, our activity started rising and has been rising ever since. And that meant we've got the challenge of managing our activity within a prescribed financial envelope. Fortunately, for the first half of the year, we've got additional COVID money, which has allowed us to meet this increase in demand. However, the second half of the year is still subject to negotiations between Treasury and Department of Health, and we don't at this point in time know what's going to happen, but we do know it will be a challenge. Our full accounts, without any omissions, is available on our website along with the annual report. However, there are a few key facts which I think it'd be appropriate to share with you, and the following slides pick those points up. But the main one I'd like to say is that another year, for in fact 5th year on the trot now, we have hit all our financial targets.
Thank you very much, Mike, for that run through the annual accounts and the recognition of a clear bill of health and having achieved all our financial targets. Once again, that's great news. We're going to move straight on then to our last video of the AGM today, and that's from our colleague Will Legg, who is our Director of Strategy and Transformation.
Hi, my name's Will Legg and I'm Director of Strategy and Transformation for East Midlands Ambulance Service. We created the Big Three before the pandemic, and we've recently taken a review in our Trust Board to make sure that the Big Three are absolutely the right strategy and the right things for us to be doing and serving you as the public into the future. We've learned a lot through the pandemic about how to run effective ambulance services when under real pressure. The different parts of the Big Three, so the respond, develop and collaborate aspects, really have shone through. We've responded by making sure that we've been supporting our staff, we've been making sure that we've got the most up-to-date vehicles available and putting our services together for you, the public, and responding in the best possible way available. In terms of develop, we've been supporting our staff health and well-being And we've been continuing to develop our skills on the front line with new roles such as the specialist paramedic, which are now out there across the communities of the East Midlands. In terms of collaborate, the pandemic meant that healthcare services had to collaborate together in a way that they've never had to before. Everyone had to pull together, and we were no different in the ambulance service. We worked really closely with our hospital colleagues, general practice, so doctors, across the whole of the East Midlands, and we've tried new ways of working, we've done things differently, and we've learnt so much through that process. All of that learning we've reviewed, we've taken on board, and we're now designing that into our long-term future, making sure that our services are sustainable and making sure that we can get to you and give you the service that you need when you need us there. So the new health and care bill that's just been published really does align nicely with the collaborate part of the big three strategy in EMAS. I say that because the collaborate part is really where the new integrated care systems are really focused. That's a core part of the new bill. What that means in reality is that we'll have closer working with colleagues from, say, 111. I know that a lot of the public call 111 for assistance, and that means that when we need to be involved in that call, because sometimes 111 calls do go to 999, we'll make that journey smoother and more appropriate for you clinically. There are other parts of the collaborate agenda which we're strengthening as well, such as working with local general practices. We've got a rotation scheme which is starting for our frontline paramedics for them to work with our colleagues in primary care, which means that they'll gain skills from primary care while supporting general practice, and they'll rotate back into our workforce and have even more skills than they had before. This is a really big development for us, and it's another way that we can support our staff in the organisation to develop and provide you with the best possible care across the East Midlands. One big part of the new Collaborate agenda and integrated care systems is something called provider collaboratives. Now, provider collaboratives are a way of organisations formally bringing themselves together. It's not a merger necessarily, it's more of a cementing of relationships that have been built over the years and obviously driven through the pandemic as well, between organisations such as East Midlands Ambulance Service, the local hospitals, community services, mental health providers. It's a really interesting and new innovative way of making sure that those organisations work closely together, deliver fantastic outcomes for patients. And what I mean by outcomes is delivering you the right care when you need it in the most effective way. Nobody likes to be bounced around between different organisations or different parts of healthcare, and we really don't like doing that with patients either. Provider collaboratives offer a really genuine new opportunity to make sure that we can deliver seamless care between ourselves as organisations, and we don't end up in that situation where you're moving between services unnecessarily. As part of our long-term developments, we will want to engage with you, the public, and you, the staff, around how we develop our services further. Some of this might be about the different roles that we have in East Midlands Ambulance Service, how they work in the future, but also some of it might be about how we deliver services and the kind of things that you expect from us as an ambulance service. We all know that we need to respond to you when you need us. However, there's different ways of doing that. And what the pandemic has taught us is that sometimes new innovative ways using digital technology, whether that's through video or whether it's through other means, is actually sometimes preferable to patients in terms of how we respond. So this isn't necessarily about what EMAS wants, it's about what's right for you as the patient. And we'd love to hear from you in due course about your feelings around the use of those kind of technologies and new services as we move forward.
Thank you very much, Will. Just before we move across to questions and answers, while we wait for some more questions to come in, I was just going to start by asking Richard a question, if you don't mind, Richard, and that is, at the beginning of last year, 2021, sort of April, May, June, July time, over a year ago, our performance metrics, if you want to put it that way, our response times were excellent, the best we've ever seen in EMAS, and I think other ambulance services experienced the same, but it doesn't feel like that now. And I just wondered if you could just explain some of the differences?
Yeah, so you're absolutely right, Paul. We in that first quarter of the year certainly saw a huge change or shift in the demand profile of the activity that we get into the ambulance service. And what was very evident is when you have a simple calculation of resource availability and demand, when that's in balance, we can get to patients very quickly all the time, and that was happening on a consistent basis. We do, however, know that during that first period, there were some members of the public who didn't access emergency care when they actually needed that wasn't just in the ambulance service, that was in the whole of the emergency care pathway. So we would always encourage people when it's a true emergency to ring and call for help. Having said that, what we have seen is a huge shift now, where we're in a place where the activity has changed significantly the other way, where it's grown to demands much greater than we've ever experienced before, where we do have other challenges in the system. For example, when we have taken patients to the hospital, even though we are proportionally taking fewer than we have done previously, when we're at the hospital, there have been many examples where our crews are unable to hand their patients over in a timely manner, and therefore that has a negative impact, so that we can't get to the next call in a timely manner. So simply back to the first quarter of the year, all of those factors were in balance. We had very low delays at hospitals. We had activity levels which were much more akin to what we would have expected, and certainly for an emergency ambulance service, and our resources were more readily available. So that's something which we need to clearly work with others to do everything we possibly can to encourage the activity to go into the right bit of the health system. Yeah. So always saying to people, when it's a genuine life-threatening emergency, the ambulance service is here, the 999 system. When it's a non-life-threatening emergency, there are other aspects of the healthcare and social care system which are more suitable. So that could be 111 online, for example, the 111 service, self-care, using a pharmacy. There are other examples, but always encouraging people in a life-threatening situation to ring for an ambulance.
Thank you, Richard. And actually, that's not dissimilar, I think, to a question we've had from Helen Miller from Health Watch Nottingham. And Helen has asked, are you experiencing increased calls relating to non-urgent, life-threatening conditions? And if so, why do you think this is?
So the short answer to that is yes, we are absolutely seeing an increase in non-urgent calls. I think it's fair to say that there are multiple reasons as to why that may be. That may be because patients have not been able to get immediate or timely access to primary care, for example, or have not been able to utilise other services which they may have normally done, or they may have gone straight to the 999 system. So probably back to my earlier point, always encouraging people to, in an acute emergency, ring for an ambulance. However, in those more urgent needs, there are other providers which are more suitable to meet those needs.
Thank you very much, Richard, and I hope that's answered your question, Helen. We've had another question posted from Sarah, and Sarah wants to know, how do we feed back failed pathways to alternative service providers? Okay, so numerous routes there, and that's both from our frontline operational staff, where evidence is provided, and our staff within the Emergency Operations Centre. We have multiple systems internally in the organisation where we would engage with those local systems to provide that feedback, because it's really important that we do, because where we believe pathways to be in existence and where they are available, we need to give the feedback as to whether they are truly accessible and effective. Because if the pathways are not accessible and effective, ultimately we need to ensure that they can either change or be further improved. Because we have really good examples of where our crews are able to utilise crews on a daily basis, helping them with their core role. But also the evidence stacks that we are leaving more patients either at home or referring them to alternative providers. So we have some really robust pathways, but equally I am aware that there are some challenges. So we need to make sure that the wider healthcare system again is provided that evidence. Thank you very much, Richard. I'm not sure that we've got any further questions. So if there are no further questions from our colleagues that are dialed into the AGM, I'd like to take this opportunity to thank members of the executive team and our communications team for pulling together everything for the AGM today. It's been quite difficult. It doesn't feel quite right still, not being able to see you all face to face, but these are the times that we find ourselves in. Well, how long? We did this last year, if memory serves me right, and I thought that would be the last time, but here we are again today, having a virtual AGM. So thank you so much for taking the time to dial in and join into the AGM. It is much appreciated. It was a very challenging year, a very difficult year, and quite a sad year for many of our colleagues working on the front line and behind the scenes at EMAS. But I think you've heard today as well that we have been able to make some positive steps forward, particularly around our quality improvement strategy and around our clinical strategy, which at the end of the day is why we all turn up at EMAS, to make things better for our patients and for the people of the East Midlands. So thank you very much. I hope to be able to see you face to face next year. Thank you very much.